So on those slides, you will see a special icon to remind you that this could be asked in the examination as well. So the simpler parts of it, I'll go a little fast, and the things which are a little complex, we will deal with a little slowly. So first thing that I want to cover in this presentation is that why do we need TPN at all? What is the basic composition of TPN? When to start? How to deliver it? What precautions should one take when you give TPN? How to monitor? And some common do's and don'ts in parenteral nutrition. So, as you know that parenteral nutrition started much later than ventilation. And for a pretty long time, a lot of units just ventilated, went on CPAP, put central lines, used inotropes and whatnot. But parenteral nutrition took some time to develop, and many units were not using it. I think it's only in the last, I would say, 10 to 15 years that NICUs have started using TPN. So all the time, people try to get away with enteral feeds only. And the reason for that is that people at that particular time did not understand that nutrition has a tremendous impact in the long term. Of course, immediately, no matter what kind of disease you have, nutrition is the bottom line. Whether you have a lung disease or you're having a problem with sepsis, nutrition always is going to be a determinant of your outcome. Everyone thinks that TPN could lead to complications, and anything that is not done well will always have complications. Whether you put a central line or whatever procedure you do, you have to follow the right protocols. And TPN was always felt as an additional cost. Already NICU care is so expensive, and people feel that you're going to be giving TPN again, something which is very costly. But if you see the overall costs of neonatal care, you will understand that parenteral nutrition is not as expensive as we think, especially when we compare it with the other costs of NICU care. And I'm going to touch a little bit about cost in the end of this presentation. So sometimes I feel that, we should have a nutrition monitor as well. We have so many other monitors that we use. So on the rounds, you must always see what's happening to the nutrition of the patient. And in our rounds, we never complete the round without a detailed discussion about what is the intake, what is the kind of feed that we are giving the child, what is the calorie protein, it is enough, is the child growing sufficiently well. All these things are checked on the round before we move on to the next patient. So it is an important part of the round for every critically ill child. The small preterm babies, they have very little stores. So at 28 weeks, for instance, the total fat stores are only 20% of a term baby, and only 1/4 of a term baby the glycogen stores. And you can imagine that with the kind of morbidities that these babies have, these nutritional stores are going to be depleted very fast. When the baby is in the womb, the baby is already receiving parenteral nutrition. So there is, from the placenta, there is a continuous supply of glucose. The fetus is already getting proteins at 3 to 4 gram per kg per day, and lipids around 3 gram per kg per day. So when this fetus becomes a preterm infant, and when we start early parenteral nutrition, the baby is metabolically already adapted to getting these nutrients intravenously. So we are not doing something which is very different. So now in the NNF guidelines, it is said that all level 2 and level 3 NICUs should have a facility for PN. And these units should have a space specifically designed for dispensing parenteral nutrition. And if you see the accreditation guidelines now, whether it be NNF or IAP or NABH, all of them now put parenteral nutrition as one of the essential criteria for parenteral nutrition. So many units now have developed this facility. We have been speaking a lot about this word EUGR in the last decade. And the reason for this being that small babies, if you are not up to it with the nutrition, they are going to lose a lot of weight and develop a lot of morbidities. I've shown an example of this baby, just a 29-weeker, 910 grams, was referred to us from a unit outside, kept nil by mouth for 11 days, started on TPN only on day 6, and they could attain a maximum of only 3 ml of feeds. No HMF was added because the feed volume was very small, and you can see the growth chart on your right. And you can see the drop in the weight and the head circumference also, the length also becoming absolutely flat. So this is the kind of problem that these babies would tend to face. The next thing that we would be talking about in this presentation is about the reason why nutrition is important. So it was always thought that this particular child, if you don't feed them well, these children are going to have problems with their growth. And it's very understandable. So poor nutrition, poor growth. But the problem that was mainly understood earlier in this century is about the effect of nutrition on neurocognition. And when that was realized, I think Professor Ziegler coined the word aggressive nutrition. And babies were made to grow well, not so fed well, not only to grow, but also to improve their neurocognition. And there have been some evidence to that effect. Now, this is a very famous study called the Stephen study. And in this particular study, you can see we are talking only of the first week, and we are talking of the neurodevelopmental outcome at 18 months. The amino acid intake on the left of the slide, you can see that if you increase the amino acid intake by 1 gram or 10 calories in the first week, you are going to get higher MDI by 8 points. And again, you can see here, because the energy intake, higher MDI by 4.6 points. So just the first week interventions causing a change in the neurodevelopment outcome at 18 months shows that how sensitive the brain is to nutritional needs in the first week of life. And whenever you see any talk on parental nutrition, you'll always see this Stephen study, which is regularly shown in this particular child. Now we so far have seen that the small babies have limited stores. They will develop protein and calorie deficits. And secondly, we have seen that postnatal growth failure is common and you have to prevent EUGR, not only with respect to growth, but also with respect to their neurodevelopment. Coming now to the goals of nutrition, which were laid down earlier in this century by the American Academy of Pediatrics. And they said that come what may, no matter what the baby has, you must try to prevent postnatal growth failure. And the concept of aggressive nutrition, which was brought in, it said that we have to have uninterrupted transfer of nutrients to babies after birth, and we should try to attain in utero growth rates. It was believed for a very long time that achieving in utero growth rates was very, very difficult to begin with. But now, the kind of nutrition that we practice, we see that it is really possible to achieve those growth rates, especially a rate of 15 to 20 gram per kg per day is something that is not difficult if you are doing the right things. And if you cannot achieve that full target of in utero growth rate, at least achieve optimal growth. So we have changed our pattern of feeding, and we now would aggressively chase growth and see that the babies don't develop EUGR. Let us talk a little about the nutrients that we use in TPN, and we classify them as macro and micronutrients. The macronutrients are carbohydrates, proteins, and fats, and the micronutrients are calcium, phosphorus, trace elements, and vitamins. So in the macronutrients, there has to be the right distribution between carbohydrates, fats, and proteins. And you can see on the right of the slide here that the carbohydrates have to be 50 to 60% of the total intake, fats 30 to 35, and proteins 10 to 15%. Now, it's very difficult to remember ranges. So what I generally teach students is just remember 60, 30, and 10. So 60 for the carbohydrates, 30 for the fat, and 30 and 10% for the protein. Now, this is again a question commonly asked in the exam, and this is the icon I was referring to. So you will always be asked by the examiners about how will you plan the TPN. So this you should know 60, 30, and 10 should be the distribution. There is nothing much to talk about the carbohydrates. This carbohydrates is going to be your glucose that we commonly use. And the GIRs are between 6 to 12 milligram per kilogram per minute. And we always titrate the GIR as per the blood glucose concentration, nothing different for TPN. Only in TPN, we sometimes need hypertonic dextrose. So you might need 12.5%, sometimes 15 or 20% also, because some babies are fluid restricted. So carbohydrate management is exactly as we do in a normal IV fluids. And blood sugars are generally maintained between a level, say, between definitely above 60 on parenteral nutrition, but we would put a upper limit around 150 to prevent osmotic diuresis. Coming now to the different proteins that we give the children. Now, these small babies should be started with minimum 1.5 gram per kg of protein. And I remember the olden days when we started TPN many years ago. We were taught to start with a dose of zero point 0.5 grams, grade it up to 1 gram on the next day, then 1.5, then 2, then 2.5. But now it is known that you cannot start with anything below 1.5 gram per kg. And yeah, so that is what is to be done. And of course, you must have sufficient calories to go along with the proteins that you are providing. Proteins can be increased to a maximum of 3.5 gram per kg. And we don't have many options with the commercial brands. It's aminoven 10% is what most of us use. And one must know that this cannot be used as a direct infusion. It is always added to the dextrose and electrolyte combination. There are some adult solutions in the market which are a little cheaper, but they're not to be used, especially for preterm newborns. The amino acid solutions that we use have a very high osmolarity, and that's why they should never be given as a direct infusion into the vein, always mixed along with dextrose and electrolytes. So this is another thing, always kept amino acid solution and lipids are kept at the table for drugs in the vivas. And one must always know that is hyperosmolar, not to be infused directly. And they will always, the examiner will ask you about what dose you will give and how will you grade it up. So minimum 1.5, maximum 3.5 of 10% aminoven solution. Calcium, again, nothing very different with calcium. Again, it's a part of TPN for preterm babies to be started on day 1. The dose would be 2 to 4 milliequivalents per kilogram per day. It is also part of the amino acid dextrose electrolyte mix. And you are already well aware of how much milliequivalents of calcium 1 ml of 10% calcium gluconate would contain. Again, the lipids now an important part of TPN. They take care of the calories component. These lipids contain triglycerides, which are derived from soybean or safflower, and they contain phospholipids, which are being added for emulsification of the fat, and they have glycerol to maintain the isotonicity. So these lipids, they have molecules like the chylomicrons, and when they're infused, they're hydrolyzed into free fatty acids by the lipoprotein lipase, which is there in the endothelium. And preterm babies have limited activity, so they do not tolerate lipids very well. So we'll talk about the doses later, but these are about the lipids. This is the SMOF lipid, which most of us use. This contains a combination of 4 things: soybean oil, MCTs, olive oil, and fish oil. So the benefits of adding these 4 are these are much better tolerated. They are anti-inflammatory, and we use a 20% preparation, and the rise of triglycerides which you get in response to lipid infusions is lesser when you use the SMOF lipids, and most of us would be using this particular lipid. Now coming to, I just mentioned earlier that lipids are a source of energy. They are needed to prevent essential fatty acid deficiencies. As compared to the amino acids, the lipids are isoosmolar, and they would give 2 kilocalories per ml when you use the 20% solution of SMOF. So coming to the calories and proteins that you require on parenteral nutrition, this is something that you must be aware. So when we want to prevent a catabolic state, which is the first aim in any critical ill baby, 50 cals per kg, around 2.5 gram per kg protein would be fine to prevent a catabolic state. If you increase the calories to 70 to 80 and give 3 gram per kg of protein, you get a positive nitrogen balance. And if you give up to 110 cals per kg and your protein go to 3.5 or 4, that is the time you actually get growth.
Sorry to interrupt, sir. There is a question. Do you like to answer now, or we can take it at the end?
Just give me only 1 minute. I'll just plug in my laptop. I'm running low on the battery. So just give me 1 minute only.
Okay. Pragya, I think it's best we take the questions at the end.
Okay. Okay.
Yeah.
Yeah. Thank you.
But everyone do put your questions as you think of them in the chat. We will address them at the end.
So sorry for that interruption, but what I was trying to mention is that your calories and proteins first aim preventing catabolism, then positive nitrogen balance. And if you want to have growth, then around 110 calories per kg, and you would go to around 3.5 to 4 gram per kg of proteins. Now, this is another question that is commonly asked in the exam, and it's a very common OSCE that I've seen in many exams, and invariably a lot of students make a mistake there. So they are asked what is a non-protein energy ratio. It's also called as the calorie nitrogen ratio. It's a very simple thing in parental nutrition. You can see the numerator here, which contains non-protein calories, which is carbohydrates and fats. And in the denominator, you can see proteins. So this calorie nitrogen ratio is calculated when you give parental nutrition. And this ensures that you are giving sufficient calories for the amount of protein that you are providing. If you don't do that, the protein utilization will not be proper, and the baby is likely to get more metabolic complications, especially uremia, or you can get cholestasis. So you must maintain a proper calorie nitrogen ratio. The normal ratio is between 150 to 250. So the ratio is below 150, it means that you are giving sort of much higher proteins for the calories that you are providing. And if it's above 250, it means that you have some scope to increase the protein in case you want to. So maintain this calorie nitrogen ratio between 150 and 250. And this formula is something that you should know, commonly asked in the OSCEs. So it's called both NER or CNR, and it ensures adequate calories for the amount of proteins that are given. Coming to the phosphates now, phosphates again, normal value 2.5 to 4.5 milligrams per deciliter, and 1 millimole of the phosphate solution would give 31 milligrams of elemental phosphorus. As you know, very important to prevent osteopenia and an important part of TPN. However, in India, you don't get it very regularly. So we use it when we can. It's available as a solution called spot phos. So very erratic availability, but an important part of TPN. Magnesium is the same that we use. So the magnesium sulfate 50%, 1 ml would give 4 milliequivalents, and the dose is 0.2 to 0.3 ml per kg per day. Vitamins, we again have problems with vitamin availability. We don't have a dedicated pediatric MVI. So we are using the adult MVI in a modified dose. We give 0.5 ml per kg. It is given from day one in preterm babies. But because the adult multivitamin does not contain vitamin A, vitamin K, we give vitamin K weekly intramuscularly to these small babies. And the vitamin A, which is present in the adult solution, we want around 1500 international units. It is, as you know, has some benefits in preventing chronic lung disease. So we are using a adult MVI solution as of now. So there are some problems with vitamins. So avoid exposure to light and phototherapy. So you just cover it with aluminum foil when you are infusing these solutions. And they do generate peroxides if they're exposed to light. So always cover the TPN lines with foil. So trace elements, again, important part of TPN. And these trace elements, the important ones are zinc, copper, then chromium, selenium, and iron. If TPN is going to be very short term, say 7 days or 10 days, you may not use the trace elements. They're usually given when TPN extends beyond 2 weeks. Preterms, however, need zinc from day one, and that is why in most of these preterms, you would be adding the trace elements early in parental nutrition. So we had problems of availability of trace elements in the past, but now I think we have a few brands. And whenever you give TPN, you must add trace elements and vitamins, especially in preterm infants. So after looking at this nutrient availability, in the past, I have seen that there were a lot of arguments about TPN that you don't get this is not available and that is not available. So currently in India, most of these nutrients that you need, the macronutrients are easily available, and you won't have any issues with the vitamins. Trace elements you may or may not, phosphate you may or may not. But for short-term TPN, say 7 to 10 days, most of the TPN nutrients are now freely available. So this is an important slide. You can see just initially focus on the left. This shows what is the protein requirement of the small babies, and the different color bands indicate the different weight groups. So the smallest babies here have the highest requirement of protein. You can see 4 gram per kilo for babies who are below 1200 grams. So it's a high requirement. The smaller you are, and in the higher weight groups, the protein requirement generally comes down. But you can see the requirement is between 3.4 to 4. So this is the requirement. Smaller you are, higher is the protein requirement. On the right of the slide, you see the energy requirement. It's a mirror image. So the smaller you are, your energy requirements are lower. And in the higher weight groups, you can see the energy requirement slowly goes up. Again, it is between 110 to 135. So this, you should be aware of the protein and calorie requirement at different weight groups. A little bit of word about protein. This protein seems to be the most important nutrient in parental nutrition. And I will show you one very, very important graph. This shows you the doses of protein on this x-axis. And on the y-axis, you can see the nitrogen retention. So you can see that anything that is below 1 gram per kilo, you can see these dots here in various studies. Every dot indicates a study, and you can see there is a negative nitrogen balance for any dose that is given below 1 gram per kilo. And it's only when you give above that, you can see positive nitrogen balance in these studies with doses which are above 1.5. That is the point where we spoke about at minimum 1.5 gram per kg. So there is no point in starting proteins anything below this level because you'll continue to have a negative nitrogen balance. There is also data to show that if you use higher amino acid doses, your long-term outcomes are going to be better. And you can see 2-year outcomes. See the green bars here where they were giving higher amino acid intakes. And you can see that these babies, lower incidence of CP, hearing is the same. MDI, again, the lower MDI below 70 is lesser incidence in babies who are given higher amino acids. So amino acids is not only important in the short term, but also in the long term. But people always say these babies are very small, they have immature kidneys, they'll get metabolic acidosis, they'll get azotemia. So is this protein really safe in very young babies? Because we are so gentle in everything else, and why we have to be so high on the protein intake? So there is enough data to show that even in the small babies, use of parental nutrition actually has positive benefits on outcomes, and it does not increase the morbidity and mortality. And there is enough evidence to show that TPN is very safe even in the smallest babies. Of course, remember if the baby has a renal problem, then generally you should not exceed a protein dose of more than 2 gram per kg. Sometimes we restrict to 1 gram per kg, especially if there is renal impairment. So the second important message would be that one, start amino acids on day 1 and start with a decent dose of at least 1.5 gram per kg. And these early amino acids are going to have a positive impact on short-term growth and also on the long-term outcomes. A few words on the lipids now, that these small babies have very little fat, and these babies' lipids also are to be started on day 1. And in good old days, when we did TPN, we usually started the lipids on day 3 or sometimes even day 5. But now there is again enough evidence to show that lipids have to be started early along with the proteins. Lipids are isoosmolar. They are the energy source. You will get essential fatty acid deficiency if you do not start lipids early. And the PUFAs that you get from the lipids are going to be very important in brain and retinal development, and they prevent a catabolic state and are protein sparing. So when TPN started in India many years ago, a lot of units said that we give TPN, but we don't give the lipids. So then I used to say that that is not TPN, that T means total. So then your parental nutrition is partial. And every time I talk in any conference, people say, "Nahi, hum dete, but we are very scared of lipids." So there's nothing to be worried about. Lipids, in fact, are very safe. And if you want to give good parental nutrition, remember lipid is an important component of that. So start on day one. They are an important source of calories. So we already saw that around 30% of your calories are going to come from lipids. Maximum dose 3, sometimes even 3.5. Always given as a continuous infusion over 18 to 24 hours. And in small babies, you should monitor triglycerides, because if your triglyceride levels start going above 200 or 250, you may have to restrict the lipid dose. And I already mentioned early in the talk that the lipoprotein lipase is limited in preterm babies, and these babies can have intolerance to lipids. So always monitor the triglyceride level. So again, starting dose 1 to 1.5 grams per kg. You can grade it up to 3 gram per kg over the next 2 to 3 days. Grading up may not be always necessary, and you must have heard this word aggressive parental nutrition, where 3 grams of protein and 3 grams of lipids are started on day one. And there is data to show that it is very safe, and a lot of units still practices aggressive nutrition. Now, what we do in our unit is we start with amino acids of 2 gram per kg and lipids of 1 gram per kg in the small babies, especially those below 1 kilo. And then we slowly grade it up. But there are a lot of units which practice aggressive nutrition also. We're starting with 3 and 3. So as I mentioned about parenteral nutrition amino acids, even early lipid administration has been shown to be very safe in many studies. And there is no difference in mortality, chronic lung, jaundice, thrombocytopenia, sepsis, all these morbidities which once upon a time were thought to be having a big problem with lipids. Now we know that there is enough data to support that if you give the right dose and infuse over a period of time, then you are not going to get these additional complications on TPN. So when we start a TPN program, we just see that everything is available. We are going to see how to calculate it. People are worried that they might need expensive equipment. Will be there complications, how expensive it is, where can we get trained in TPN? All these questions keep coming. And any new unit that is starting, all these things will come to your mind. So first thing to know is that when you decide to start TPN on any baby, there has to be reasonable hemodynamic stability. If the patient is in shock, you're pushing boluses, you're on very high inotropes, you may hold back a little. It doesn't really matter, but child should be in hemodynamic stability. The electrolytes should be reasonably normal. The glucose requirement should be stable. The child should not have uncontrolled sepsis and DIC and things like that. So the reason why we need some stability in the baby before starting TPN, because once you make up your TPN and put it up, and then your sodium level comes low, your blood glucose drops, you cannot keep on repeatedly removing the TPN, again recalculating, again mixing and putting it up. So all those things are not right. So we always wait for some stability before we start TPN. Sometimes it may just take 6 to 8 hours or something, but unless you have a reasonable idea of the other issues, never start TPN in a hurry. Honestly, nothing much is required for TPN. You can see in the top of the list is a laminar flow system that is required to make the TPN. Secondly, the rest of the things in the list, that we already have most of these things in NICUs, and we just need a dedicated TPN room. So I'd gone to Bangalore for an accreditation, and I saw that kept the laminar airflow system right in the middle of the patients. So that cannot be. The laminar airflow system should be a little away from your patient care area, preferably in a separate room, because we do not want any contamination when we are making our parenteral nutrition. Most of the other things you see here are all there in most of the NICUs which we have. So for many years, I was doing TPN. I used to do most of these calculations and mixing and setting it up. I used to do it alone for many years. But later on, we created people who can do that, and we picked up nutrition graduates from universities and we trained them into TPN. And now our program is usually run by dedicated TPN nutritionists, and we just tend to oversee them. But most of the times, we don't have to do much. They are fairly experienced in this. And when any facility is handed over to very dedicated staff members, then your complication rates tend to be a little on the lower side. Of course, everyone must have basic knowledge, and the residents must know that when you handle TPN, you have to take all sterile measures. The nurses should know what you can give through the TPN line, what you cannot. So basic knowledge everyone in the unit should have. So we identify babies who need TPN on the rounds, we calculate the needs, we prepare it under laminar flow, we set it up on the patient, and we do daily monitoring. In our unit, all these jobs are done by the TPN nutritionists, and all babies below 1500 grams would automatically be started on TPN right from the time of admission. So this is the kind of policy we follow. Some units follow a cutoff of below 1250 grams, some below 1 kilo, but in our unit, above, I think 1500 grams, we find is a reasonable cutoff. Even the NNM guidelines would give around 1500 grams for starting routine early TPN. So Dr. Suman was referring to the software that we use, and we developed this software over many years. So when you have a unit where say 8 to 10 babies are going to be receiving TPN on a particular day, the manual calculations can be done, but it's always a little tedious and is always subject to error. So whenever you're doing some mathematical calculations, always better to use a dedicated software, because this software, one, is standardized and it does not allow for errors in the calculation. In fact, there are sufficient number of safety checks. So suppose you put a wrong value, suppose potassium by mistake, you put 7 milliequivalents per kilo, the software will actually warn you and not give you a printout. It will say the dose has to be between these two only. And that actually reduces a lot of errors that can occur in parental nutrition. So this software is freely available. It is cloud-based, and anyone who wants it, even for free trial, can have it and try it out. It is not at all expensive. So this is what the screen shows. You can see the various things that you enter: day of TPN, what is the weight of the child, what dextrose concentration you got, what's your fluid intake. These are things that we normally do. And here, the scroll bars show you how much amino acid, sodium, potassium. You just scroll them up and down, and whatever you want, you can see the figures changing on the top. And then you calculate. So this will give you a complete idea of what requirements you are going to have. And it gives you a printout of the volumes plus a printout for the patient files. The important part of this software is it also has the enteral component. So if you write how much feeds your baby on and which feed are you giving, are you adding a fortifier, it will also give you the enteral calories and proteins, and it gives you a complete composite report of how many calories you are giving, how many enterally and how much parenterally, and this becomes a ready reference for you. It stores real-time data, so you can use that data for later use. So suppose on day 13, how many calories, proteins, how many of enteral, how many from parenteral, and this software also plots a growth chart automatically. So you know what you are giving, and you also get an automatic growth chart to see what your nutrition, what impact it has on the child. So this is a thing on the round. So the software is on this tablet, and every baby that we do, we will check the calorie protein intake as well as the growth at the bedside. So you can scale up your nutrition based on the kind of growth that you would get. Coming to preparation of parenteral nutrition, we always would recommend preparation under this laminar flow system. And you can see our TPN nutritionists who are getting ready. And this is a TPN room which is inside the unit but away from the patient care areas. So the TPN is always prepared under this, and people say that no, we don't have a laminar airflow. Can we make TPN? So it can be done in the room also in a relatively clean area, but a laminar airflow system is not a very cumbersome or a very expensive device. Most of these very good large units will be available for around ₹1,00,000, which according to me would not be a very prohibitive cost. In countries abroad, they use automated systems for TPN compounding, and it will be possible that one day we will go away from manual compounding, have such automated machines and do our TPNs. I don't think that would be difficult. The problem is these machines are expensive, but cost is not the only factor. We don't have sufficient units having this automated compounding. So the company doesn't find it very convenient and economical to set up units and have a dedicated engineer. But I think many hospitals do install such systems. There'll be one day when we'll go off manual compounding completely. There is a relatively simpler solution now that there are some companies which are planning to have the standard PN solutions which are off the shelf. So you can see here 1%, 2%, 3%. So instead of compounding, you can directly pick up the solutions and put it up on the patient. and in a particular fluid administration volume, they would tell you how much calories you and proteins you would be providing. You must have noticed that lipids are not a part of this. So if you intend to give lipids, they will have to be given as a separate infusion. So we are now thinking of making such kind of standard PN solutions. The other thing is that when we administer these TPNs, we give the lipids separately and we put all the other things in a different bottle. So amino acid, dextrose, electrolytes, trace elements, heparin, and vitamins are all put together, and lipids are given as a separate infusion. There are some units which put vitamins into the lipids, so that may also be done. But as of now, because the vitamins are water and fat soluble both, and we don't have dedicated MBI, we are putting it in the amino acid and dextrose solution. A lot of people used to say that, we don't give TPN because we don't put center lines. So you must know that parenteral nutrition can be given from peripheral line as well. Only remember it is hyperosmolar, so you must have a large vein and it has to be monitored very closely, and one must avoid extravasation. Of course, all of us use PICCs now, we use umbilical line, so TPN can be given through umbilical line as well. For if you're giving dextrose about 12.5%, and you're going to need TPN for a longer time, it's always better to use a PICC for giving parenteral nutrition. Do's and don'ts are commonly asked in the exam. So basic tools are strict asepsis, scrubbing and gowning is required when you set up the TPN, use a laminar flow system, change your infusion sets every day, and use infusion pumps. And the don'ts would be that, just putting gloves and trying to make TPN, then using the solutions beyond 24 hours is generally not recommended. Breaking into the TPN line for antibiotics and such things, also this, as far as possible, once you set up TPN, you should not break into the line. And untrained people doing TPN, strict no. We train a lot of people in our unit on the laminar airflow system. So if you see this monitoring chart, if you see a textbook, it shows a huge chart with, monitor sampling at virtually doing this daily. Then LFTs you should do twice a week, and calcium alkaline twice a week. So if you see this chart, these anthropometric measurements we normally anyway we do it. Blood sugars and all we check fairly routinely in these small babies. With the babies ventilated, blood gases are usually done. And electrolytes is something that you need to do, especially early in the parenteral nutrition. Later on, you can do it once a week. Even your LFTs and renal function can be done once a week, especially if your baby is very stable and not very sick. So this also, again, we have modified this monitoring schedule depending on the stability of the baby. And I mentioned about the cost in the beginning, and this is a cost for an individual patient, which we calculated last year. So the nutrient solutions, lipids and amino acids and other nutrients, use of disposables that we require special sets. Biochemical monitoring, we have taken a daily cost, and we also charge for TPN preparation because we have to pay our nutritionists. Comes to around 3,000 rupees. And of course, the laminar airflow and the infusion pumps, which are the capital cost that you invest. Now, this is for a single patient. But suppose we have 8 to 10 patients in the unit on TPN, the cost of the nutrients gets divided. And when we share these nutrients between patients, it becomes much more cost effective. We use modest nutrient doses. We prevent complications because complications add to the cost. And though it is said that you cannot reuse the nutrient solutions, we apply this strictly to the lipids, because if you break into a lipid bottle, you lose the nitrogen, which is packed into the bottle. So the lipids you should not be reusing at all. Amino acid solution, sometimes we do use on the next day, though it is not recommended at all. So I'll just summarize my talk that we have seen that parenteral nutrition is an essential part of your care of preterm and low birth weights. Early nutrition not only affects growth, but neurocognition. We still feel that TPN is underutilized because people still feel it is costly and it may cause complications. But now, because of the accreditation requirements, most units are setting it up. But you must do total parenteral nutrition, not just partial. Most of the babies in NICUs or preterm, low birth weight, NEC and surgical patients are the ones that really need parenteral nutrition. While calculating TPN, remember, preventing catabolism is your first aim. And aggressive nutrition is a concept. We are somewhere in between. So we are not just limiting the catabolism or going aggressive. We are somewhere in the middle. I think that's the right path, especially in the small babies. And everyone should have a nutrition support team. Try to look for resourceful people who can do and monitor your TPN. Most of the products we already have, and the market will keep on improving over a period of time. And I'm sure that we'll get better and better products as time goes by. So these are the CPG guidelines of the NNF, and there you will find most of these protocols which I mentioned today. So all of you can go now. These are all available on the NNF website. So you can get a copy of these parental nutrition and newborn guidelines, which will be useful for you to read. So thank you very much, and I think now we can open up for the questions.
Thank you, sir. Thank you very much. It was such an engaging presentation that I was also glued to the talk today. We have a lot of questions, and I'm sure more will be coming. I request Dr. Pragya to discuss the questions, to present them to sir.
Sure, ma'am. So first question we have from Dr. Swati. Can we give amino vein without dilution and run in the same vein as IV fluids?
As I mentioned, that the amino vein solution is very hyperosmolar, and it should ideally be mixed with your dextrose solution before giving it and given as a controlled infusion. Remember, when you suppose this 1 kg baby, you're giving 1 gram per kilo, the volume is going to be only 10 ml. So one should not be infusing that 10 ml in a small syringe directly into the vein. It can be part of your dextrose and electrolyte solution. So better not to give it as a direct infusion, always asked in the exam. So you must, if the examiner gives it to you, always mention that it's part of the amino acid dextrose electrolyte solution.
I hope this is, thank you, sir. The next question is from Dr. Gayatri. Will aggressive nutrition has any side effects of obesity or metabolic syndrome in long run?
Yes. Now, this controversy about early growth and, inducing metabolic syndrome has been going on for a very long time. But though the final word on this is not said, the general consensus now is that at least in early infancy and especially neonatal period, focus a lot on growth. That is the time not to worry too much about the metabolic syndrome, because the brain and neurocognition is top priority in early life. It is now said that metabolic syndrome usually occurs as part of accelerated growth later on. And that is the reason why initially, at least in the first year of life, our focus is more towards aggressive nutrition. And later on, we would tend to prevent obesity and excessive fat accumulation. Of course, I must also mention here, there have been some studies that have shown that accelerated neonatal growth can lead to metabolic syndrome. So as we know, the final word on this is still not said. But as of now, we are still in the same we are not overdoing things, but we certainly give you the minimum requirements, which I showed 1.5 gram of, say, protein or a gram per kg of lipid. I think that would be relatively safe rather than giving very high proteins. I think particular caution should be taken in the growth restricted babies. For an SGA baby, try not to go on the higher side of the nutrients.
Thank you, sir. The next question is from Dr. Chandrasekhar. How to manage phosphate supplement in TPN?
Yes. So the issue is that this phosphates one is very erratic availability, but when you have them available, you should use them. Phosphates by themselves will not cause a problem, but phosphates cause precipitation with calcium, and especially if the ratio is not right. Now, when you make your TPN, it's very difficult to see the precipitation in the bottles. So there are some very standard recommendations for adding the calcium and phosphorus. There's also sequence of mixing. But what we do is, because we are a little worried about the precipitation, if we are adding phosphate into the TPN solution, then we tend to give calcium separately into the vein, like we give it for other children. So we would give it, say, every 8 hours as a small bolus rather than adding it to the TPN bottle. But we are trying to now talk to the physics people to see that suppose we add different doses of calcium gluconate and the phosphate preparation, we are going to study in the lab what exactly in what doses causes precipitation and what would be the right sequence of mixing. But till the time we are very sure about it, it's better to infuse them separately.
Next question is, do we need to withhold lipids if baby has thrombocytopenia?
Yes. So thrombocytopenia, unless it is very critically low, say below 10,000, I think one may withhold the lipids. But for most of our babies, we will continue to give lipids at 1 gram per kg per day. It is now seen that it is the rate of infusion that is a major determinant. So if you are going to give 1 gram per kg per day, remember whether it is sepsis, whether it is jaundice, whether it is a chronic lung disease, whether it is thrombocytopenia, 1 gram per kg lipids infused over 18 to 24 hours would be safe in majority of these conditions. So you may not hold back lipids if the unless the platelets are very critically low.
Thank you. The next is, intralipids can be given with PICC line if IV access is difficult.
Yes, in fact, intralipids are to be given through PICC line only because they are very safe to give through that. But you can also give them through a peripheral vein because I mentioned that they are isoosmolar and they would not cause much of IV trauma like your proteins and dextrose would do.
The next question is, how frequently should we monitor triglycerides?
Yeah, so triglycerides again, the smaller babies, you would monitor triglycerides when your dose of lipids exceeds 2 gram per kg. If you are giving just a gram per kg controlled infusion, you need not do it. So as you go higher on the lipids in the smaller babies, you should check it. Sometimes if the levels are 200 plus, we would check them every day. But we check them, I would say, every once in 2 or 3 days only, except in the very small babies and on higher doses.
Thank you, sir. The next question is from Dr. Manan. Is it necessary to taper amino when we reach 50% of feeds?
I think I did not mention them in the talk, but when you decide to wean off parenteral nutrition, generally recommended 75 percent of your feeds, if you are able to establish, then you can wean off the parenteral nutrition. So till that time, you can continue to give TPN. So reaching 75% of the enteral feed volume intake.
The next question is, role of heparin with lipid infusion.
Yes. So heparin is known to stimulate the lipoprotein lipase enzymes. So giving heparin actually improves lipid tolerance. But we usually use lipids when we give TPN through the central lines. But it also contributes to a better lipid tolerance in small babies.
We have a last query regarding the app. How we can download the Kimaya app?
Okay, I think what you can do is you can share my number with them and I will put them onto the link and they can actually access the software. You can take a free trial also for a month. And later on also when you use it, no, it is based on the usage. So it's something, the charge is something like 10 rupees per baby or something. So it's something which is very easy. It can be customized to your hospital's name and your name. And it is something that you can try it out for a month. And it is sort of just a very small nominal amount that is charged for its use. It's not an expensive software at all. So just you can sort of, if you want, I can share my email and all with someone, and it can be sent to everyone, so so that they can have free access of that software.
Sure, sir. The next question is, do you advise to taper TPN if enteral feeds are progressive?
Well, as I just mentioned, that unless you have reached sufficient volume of enteral feeds, one can continue the TPN.
Yeah, and the dose of heparin to be added in TPN should be added to both.
It is it's 1 unit per ml, and it is added not to the lipid, but it's added to the amino acid dextrose bottle. It's 1 unit per ml.
I think this is the last question. No, one more question. When to use low dose of amino acids, especially based on DUN?
Okay. Now, if there is renal impairment, generally do not exceed a dose of 1.5 gram per kg. But remember that whenever you give proteins, because of protein turnover, there's always a mild rise in the blood urea level. So sometimes it is taken as a marker of protein turnover. So unless there is some other reason for the renal impairment, one should not restrict the amino acid dose. But when we have renal failure, we still give up to 1 to 1.5 gram per kg per day.
I think we are having a few more questions are coming. The next question is parental nutrition associated liver disease and how to treat.
Okay. Now, one thing you must know is that one must focus on prevention of parental nutrition associated liver disease. Fortunately, we see very less of it nowadays. So one thing you must do is try to keep some enteral feeding going if you can. So unless it's a very surgical ileus or something, most of this baby you must continue enteral feeding. Maintain the calorie nitrogen ratio properly. Secondly, see that you give the trace elements because there are some trace element deficiencies that would cause PNALD. And if you start getting abnormal liver enzymes, you have to make some changes in the TPN. You may have to cut down on the dose of the amino acids, and you may sometimes even have to give a break to the TPN. So you must try to prevent it because parental nutrition associated liver disease, it can go to end stage liver disease. So it's not a very benign condition. Even the newer lipids that we get now, those newer lipids also are known to decrease the risk of PNALD. So fortunately, we see very little liver dysfunction now than what we saw in the past.
Is TPN-OMA and PNALD are same?
I have not heard this word TPN-OMA. Has anyone, Suman, have you heard this word?
No, no.
Mm.
So this is last question, I think. Any other questions? Anyone want to put in chat box?
Or any of the faculty? I see that a lot of faculty have also joined, so that's very encouraging. I think Dr. Kedar had mentioned. Dr. Kedar, do you want to discuss that paper? You wanted Dr. Umesh's opinion on a paper I saw.
Yeah, thank you. So there was this study which was published in NEJM. I have sent the paper to Sir's WhatsApp, and what they found that administration of 1 gram per kg amino acids in the first 5 days, 5 to 7 days, and they followed it at 2 years, and they found there's not much of a difference in the neuro disability if you give it higher dose or a lower dose.
Yeah, I know. See, there are.
So some people are nowadays advocating against aggressive parental nutrition on day one.
So in fact, there are some studies that have actually shown that if you have used higher amino acids, they have shown abnormal MRIs in preterm babies. They have also shown that you can actually increase the neurodisability if you use higher amino acids and it causes a problem. Now, fortunately, those studies are very few. But as happens in life always, if you follow the middle path, you're not giving too little or not too much, generally you would be all right in most of these situations. So we still would practice it because I think what is important here is preventing a catabolic state, because a catabolic state and EUGR itself also contributes to neurocognition. So I think the middle path, using amino acids in the right dose, monitoring them carefully, avoiding major metabolic aberrations would be important.
Thank you.
Thank you, sir. If I may ask a couple of questions which have been sort of, one is in India, there's a lot of now movement towards early total enteral nutrition, even in the smallest babies. And therefore, many of us follow the middle path, like you said, focus on enteral and focus on parenteral. But what is your thoughts on early total enteral nutrition?
Yeah, you can complete the question.
And therefore, since we are doing both and following the middle path, is that rigorous monitoring that we advocate in TPN really needed when we are giving something through the tummy most of the time?
Yes, the issues about this early total sort of enteral feeds is something that I think I'm also very impressed. And every time I hear Dr. Shushma on this, I really feel that she's a very brave woman. Now, all of us are not that brave. So for us, babies 32 weeks who are otherwise stable hemodynamically, we would go on total full enteral feeds. But I think anything below 32 weeks, I would be a little worried in my unit to do it still. I think as more data emerges, we will also be brave to do that. But the general concept is that you start with parenteral nutrition, simultaneously focus a lot on enteral nutrition. And of course, if you do well, suppose your baby is reached close to full feed by the end of 6th or 7th day, you can always back up immediately. You don't need to worry about continuing the TPN. So our priority always will be enteral nutrition, but we would also start parenteral nutrition because we know that babies do develop feed intolerance and issues. But yes, stable and bigger preterms, we are using total full enteral feeds. And sometimes, suppose the baby is 1.45, just 50 grams below 1.5 kg, we would not be able to hold back the TPN. So though our unit is a well-established TPN, we are not sort of we're trying to see when we can avoid it.
Yeah, thank you, sir. The other question was on high glucose of 10 to 15 milligram per kg per minute GIR. We frequently run into hyperglycemia.
Yes.
And we know that giving insulin is not an option. So what do you suggest when we have this? Because that sometimes is a limiting factor for us in calories.
Yes, I think you have to maintain the glucose levels in the normal range. And for that, if you want to push the calories, we don't necessarily go very high on the dextrose. And most of our patients, we would stick to a maximum of 12.5%, and the GIR would keep around, say, 10 to 12. We usually don't go higher than that. We certainly don't push glucose for more calories. We would focus more on the lipids. And there are some studies that show that they give high glucose, and along with that, they give insulin as an anabolic hormone to promote growth. And that you'll see a few papers on that. That is something I think that's going overboard. So we certainly don't use insulin for anabolism. We certainly don't use very high lipids because it can cause steatosis. And we would restrict the dextrose to around 10 to 12 milligram per kg per minute maximum. And of course, if the glucose, baby blood glucose levels are higher, then we could scale down the glucose as much as we can. And then we may have to turn down the protein also because our CNR will then be abnormal.